What's going on? Yeah. No, this one. Use this. Okay. Where am I gonna go? Okay, whatever. Okay, I don't need video. We will just start with this. Okay, Bismillahirrahmanirrahim. 29 people entered the waiting room. Yeah, don't admit them. No. Okay, Assalamu alaikum, guys. So every week the people changes. So you get used to the stuff. I have to stand near this, sorry. And then suddenly it's a different one. Okay. Okay, so this is a series of 4 lectures to cover concepts related to hemodynamic disorders. We have already covered mechanisms of edema previously, and we have done shock, and especially septic shock last week. This week, we were supposed to do 1 lecture today and 1 lecture on Thursday, but due to some logistic issue, we'll be doing half of it right now, and then the rest, inshallah, from 11 to 12. So hopefully we'll be covering all 70 slides today, hopefully, inshallah. So hemostasis, these are the objectives discussed in normal hemostasis, functions of vessel wall, platelets, and coagulation factors, and clinically correlate defects of vessel wall, platelets, and coagulation factors. And then we will be discussing pathophysiology of thrombosis and thrombophilic disorders. Some of these concepts have already been covered in the HLS block in semester 2, but we will revise them quickly just to bring everybody up to speed. I don't expect any of you to remember. Well, maybe a little bit here and there, inshallah. Okay. So what is hemostasis? Hemostasis. Okay, yeah. It is the normal physiological response that can prevent blood loss when the vascular system is breached. So everybody bleeds after trauma, like I've said before, when we were discussing hemorrhagic diathesis last week in the first lecture. And this is the normal, like when we bleed, there are systems in the body that will come into play that will stop the bleeding, okay? But we don't want 2 things. We do not want people to bleed without trauma or excessive bleeding after minor trauma. That is not what we want, because that would be pathological disorder. Secondly, we also do not want the blood to clot when it is not supposed to clot, or to form a thrombus when it should not be forming a thrombus. We want the blood to keep on flowing under normal circumstances. Now, if blood starts clotting or start forming thrombi, that would be another example of a pathological disorder. So what will be happening in this lecture is that I'll be starting with physiology. I will try to apply those physiological concepts in the context of pharmacology and pathology. So I also want you guys to think a little bit, because this is just one continuum. We start with physiology and anatomy, and we go on to pharmacology, pathology, and clinical medicine. It is just one continuum, applying the basic concepts and applying them in real life scenarios. Understood? Okay, now this involves 3 things. Hemostasis, it requires endothelium, it requires platelets, and it requires clotting cascade. These are the proteins present in the plasma that are responsible for forming the final thrombus, okay? Now there are 2 systems. One is known as the pro-clotting system, and the other is known as the anti-clotting system. The pro-clotting system, it plugs up holes in the blood vessels after trauma, whereas the anti-clotting system keeps clotting under control, okay? Now that these 3 things, the vessel endothelium, the platelets, and the clotting cascade, when they act together, they ultimately lead to the formation of a clot. This is more or less the same thing that we have studied previously, okay? Just a revision so far. Now, first thing that happens after trauma is that the first step after trauma, whenever the vessel is breached, is that there is vasoconstriction. There is reflex vasoconstriction. Now, this reflex vasoconstriction is mediated by neural stimulation and a hormone released by the endothelial cells. And the name of the hormone is endothelin, because it is released from the endothelial cells. No rocket science there. So this is the first step. The blood vessels constricts, And this reflex vasoconstriction is there to try and stop the bleeding. Okay, it is there to try and stop the bleeding. Then comes in the role of endothelium and platelets. Okay, and this together is what is known as primary hemostasis. But before we can go to primary hemostasis, just a few words about the role of endothelium. Mostly under normal circumstances, and when I say normal, I mean under physiological circumstances, there are many factors in the blood that are responsible to inhibit the formation of a clot. These factors that you see here on this side of the picture, they are there to inhibit thrombosis. They are there, and this is normal and physiological. We want the blood to keep on flowing, right? We don't want the blood to clot inside the human body, okay, unless it is needed. So these factors, all of these factors are there in the endothelium that are there to prevent blood from clotting. Okay, and there are many names. We will not be discussing or going into the depths of these names, but just to give you an example, there are heparin-like molecules that inactivate thrombin. And this thrombin is coming up later in the lecture, so I will explain it at that time. But more importantly, whenever there is trauma to the vessel wall, something is released that we call tissue factor. All tissues have this factor, factor 3, which is released whenever there is trauma. And when the tissue factor gets released, it is something that is going to favor thrombosis. And can anybody tell me how? Can you remember anything? How tissue factor will favor thrombosis or lead to the formation of a clot? Anybody? It's okay. It will start the extrinsic pathway, okay? Because this tissue factor will combine with factor 7, and that will start that is actually what extrinsic pathway is. So normally the endothelium, all these factors, they are there to not let the blood clot. But whenever there is trauma, whenever there is exposure of the collagen secondary to trauma, then the tissue factor is released, and that will favor the formation of a clot. So far, so good? Understood? Any difficulties? Okay, moving on. Now, what is primary hemostasis? So whenever there is trauma, the first thing that happens after reflex vasoconstriction is that these platelets, they will come into contact with the endothelium, and they will combine with the endothelium. And we call this platelet adhesion. Combining of the platelets to the endothelium is known as platelet adhesion. They will also undergo a shape change. So normally they are rounded in structure, small particles, but they will become more flattened. Okay. The reason they will become more flattened is, see this rounded structure is now becoming more flattened. Okay, they are becoming more flattened, and we call this shape change. There are two reasons for it. Number one, they occupies more surface area to plug the hole, and number two, they provides a phospholipid surface. They provides a phospholipid surface on which the clotting cascade can act. For the time being, just remember that they are providing a phospholipid surface on which the clotting cascade can act. For the time being, just remember that. So the first thing is platelet adhesion, followed by shape change. And then there are two kinds of granules inside the platelets. They will release their contents, okay? And that will promote more and more platelets to come and combine with each other. And the platelets, they combine with each other, we call it platelet aggregation. Very good. We call it platelet aggregation. So they will combine with each other, and they will form something that we call a platelet plug. Okay. So all of these things, all of these reactions, platelet adhesion, shape change, release of the granule contents, recruitment of more platelets at the site of injury, finally leading to platelet aggregation, leading to the formation of a platelet plug. All these 4 or 5 steps, we call them primary hemostasis. What do we call them? We call them primary hemostasis. Now, all of this is normal physiology. All of this is normal. This is what happens normally. Okay, everybody understood? Once again, this process is known as primary hemostasis. It comprises of platelet adhesion, shape change, release of the granule contents, leading to more recruitment of the platelets at the site of injury. Platelets, they combine with each other, leading to platelet aggregation, and finally a platelet plug. A platelet plug is formed, okay, not a clot. Platelet plug is not a clot. A platelet plug is formed, but no thrombosis has yet happened, okay? We call the whole process primary hemostasis. Understood? Everybody get it? Okay. Now, why? Now, the platelets have two granules, alpha and dense bodies. You don't need to remember the contents of these at all. It is just to convey a concept that they contains important proteins and material inside them. One of them is von Willebrand factor, the other is calcium. And their role will become apparent when we are discussing secondary hemostasis. But they are also coming from this source. So the platelets are source of a number of chemicals. Some of them are also chemical mediators. Some of them we have studied previously, but two of them are in red, and then I have highlighted, but they're all important. You don't need to remember the names or the contents, only the concept that platelets, they release from their granules certain important chemicals that are necessary for promoting secondary hemostasis. Okay, please remember the concept. Don't email me asking whether you need to remember it. No, you don't. Okay, now what happens is, why what we are discussing is important, because we can take those concepts and we can apply them into clinical knowledge. So the first thing that is happening, that we call platelet adhesion, these orange balls, these are platelets. And the platelet adhesion is mediated by a reaction between two things. One is a protein on the surface of the platelets, we call it glycoprotein 1b. And this facilitates the adhesion of platelets to the endothelium through a protein known as von Willebrand factor. This von Willebrand factor is important. Why? Because it comes from two places. One, we just saw it is coming from platelets. And two, it also is present in certain bodies that we call viable pellet bodies inside the endothelium. So it comes from there, and this is how the platelet adhesion happens. So if glycoprotein 1b is not there, okay, now we are taking the physiology and we are applying it in the clinical context. So some people, they are not born, they are born, there is a hereditary deficiency of glycoprotein 1b, and that means their platelet adhesion is going to be defective. Their platelet adhesion is going to be defective. When that happens, we call it Bernard-Soulier syndrome. It's a rare syndrome. It is a deficiency of glycoprotein 1b. And in this disorder, there is going to be defective platelet adhesion, okay? If the von Willebrand factor is not there, now von Willebrand factor is important in two places. It is important here in the primary hemostasis because it is responsible for platelet adhesion. You are seeing it right in front of you, right? Now, if this is not there, it is the most common inherited disorder, hemostatic disorder. We call it von Willebrand factor deficiency. And some of these patients will also have defective platelet adhesion. Agreed? Yes? So we have taken the normal physiology and we are applying it in clinical context, okay? Thirdly, there are certain proteins on the surface of the platelets. We call them glycoprotein 2b3a, and they are responsible to combine with fibrinogen, and this is how platelet aggregation happens, okay? So the platelet aggregation is dependent upon glycoprotein 2b3a complex plus fibrinogen. Now, if glycoprotein 2b3a is not there, then platelet aggregation will not happen, okay? And that is again an example of an inherited disorder, and we call it Glanzmann thrombasthenia, again a rare disorder. It's not very common, it's pretty rare. Both of these disorders, Glanzmann and Bernard-Soulier, are pretty rare disorders. But what we are doing here is not studying the disorders. What we are doing here is taking the physiological concepts that we just studied, and we are trying to apply them in the clinical context, okay? So if adhesion is defective, we will think of either a glycoprotein 1b deficiency or a von Willebrand factor deficiency. If platelet aggregation is defective, we will think of glycoprotein 2b3a deficiency, okay? Another important point is that all of these disorders, Glanzmann and Bernard-Soulier, would be examples of primary hemostatic defect or secondary hemostatic defect. Excellent. So you have understood the concept, right? So why is this important for you? This is the reason. See that diagnosis of platelet function disorders and hemostatic disorders. What we have studied, the primary hemostasis, it is important, like I've just explained to you, because these are examples of primary hemostatic disorders. So platelets can have inherited deficiencies. Okay, one is quantitative deficiency, that the platelet count is low. We call it thrombocytopenia. There are many causes of thrombocytopenia. We will not be discussing any of those today. Those are all topics for year 3 heme block. We will discuss them there over there. But right now we are trying to understand the pathophysiology of why primary hemostatic disorders happen. So we have understood that primary hemostasis is formation of platelet plug. And we have just seen that there are certain proteins that are responsible for either platelet adhesion or platelet aggregation. Okay, and if they are defective, they are not inherited. If it is an inherited disorder, then it can be an example of primary hemostatic disorder, and we also call them hereditary platelet function defect, platelet function disorders, or platelet function defect. Okay, these are examples of platelet function disorders. I've given you 2 examples of platelet function disorder. That means the platelets are there, but because glycoprotein 1b is not there, platelet adhesion is defective. Or glycoprotein 2b3 is not there, then platelet aggregation is defective. So we call them platelet function disorders. Also, now I understand that these drugs are not part of your pharmacology objectives at all. You will be studying these drugs, okay, in CBP block, which is year 3 block. But why am I discussing this concept? Because these things, these concepts that we just studied, are the targets for a number of platelet inhibitors. Now, if you remember from Dr. Broad's lecture, he told you about prostaglandin synthesis, and one of the prostaglandins was thromboxane A2, right? He told you about that when he was discussing the cyclooxygenase pathway and the lipoxygenase pathway. He told you that thromboxane A2 is a powerful platelet aggregator. So what does aspirin do? It inhibits thromboxane A2. Okay, and if thromboxane A2 is inhibited, then the platelets, they will not aggregate. And look at all the rest of the drugs, things like abscessimab, clopidogrel, teclobutine, etc. They all target glycoprotein 2b3a complexes. They all target glycoprotein 2b3a, glycoprotein 2b. Now, if a drug is targeting glycoprotein 2b3a complex, what will not happen? There you go. Platelet aggregation will not happen. So these are all very powerful platelet aggregation inhibitors, or inhibitors of platelet aggregation. Okay, so now you saw what we did. We took the physiology, we discussed the physiology, and now we have applied that same physiological concepts in the context of pharmacology and pathology. And this is the purpose of the POD block. Okay, this is the integration that we want to happen. Understood? So you don't need to remember the name of the drug, but the concept is important. These drugs, they inhibit platelet aggregation, either by inhibiting glycoprotein 2b3a or very powerful platelet aggregators like thromboxane A2. Everybody understand? You don't need to remember abscessimab, clopidogrel, teclobutine, or any of the other drugs. They are part of your CBP block, not part of this block. Over here, you only need to understand the concept that why we are discussing this. Why is this important? Because you're becoming doctors and physicians, and you should know what is the purpose of us teaching you physiology. So you take the physiology and you apply it in the clinical context. Understood? All of you will be using these drugs at some point in your life, inshallah. Usually, these drugs are used by cardiologists. And I'm pointing to Johanna, who will become a world-renowned cardiologist. No? Okay, moving on. So that completes our discussion about primary hemostasis. Then we come to secondary hemostasis. Secondary hemostasis happens after primary hemostasis, after the platelet plug is formed. And this actually starts from the release of tissue factor from the vascular endothelium, which starts the extrinsic pathway leading to the formation of the fibrin plug. Okay, so tissue factor is exposed, the clotting cascade begins, the clotting cascade makes fibrin, and the fibrin makes the plug. This is now a fibrin plug. And this traps the neutrophils, it traps the red cells, and then the factor 13, I'm going to discuss it in more detail in a few seconds. But then this fibrin also becomes more stronger by the action of factor 13. And the minute this happens, when the fibrin plug happen, this is going to complete concept number one, secondary hemostasis. Concept number two, it is going to stop the bleeding. So the formation of the fibrin plug, all the steps that lead to the formation of fibrin plug is what we call secondary hemostasis. All the steps. We are going to discuss those steps briefly in a few minutes. But right now, please remember the concept. Concept is that the formation of the fibrin plug is what is known as secondary hemostasis. And what is most important in secondary hemostasis? The clotting cascade. Okay. Now, the minute this happens, concept number three, do we want this clot to remain there forever, or we want it to go away once the bleeding is stopped? We want it to go away. So the minute this clot is formed, the second actually the clot is formed, another mechanism in the body starts that we call the fibrinolytic pathway. And we will discuss the fibrinolytic pathway. And this will start, and the purpose of the fibrinolytic pathway, look at the name, fibrinolytic, is to lyse the fibrin clot. Okay? It is going to lyse the fibrin clot so that it goes away and the blood flow can resume normally. So far, so good? Okay, now all of the clotting factors are produced in the liver. They're all in inactive form. Their activation requires exposure to activating substance of phospholipid surface and calcium. Where is this phospholipid surface coming from? Who is providing it? Platelets. And where is this calcium coming from? Yeah, you don't need to remember the name of the granules. Somebody said the name of, but it is coming from the, oh, you said granules from the platelet. Yeah, excellent. Okay. I thought she said it, but actually you said it because everybody is wearing a mask except me. It's confusing who is saying that. Anyway, so they're all produced in the liver. How many clotting factors are there? I just said factor 13. So there will be around 13, isn't it? Okay. Did you say 12? Did anybody say 12? Okay. Now there are three pathways. One is known as the extrinsic pathway, one is known as the intrinsic pathway, and the third one is known as the common pathway. There is nothing except just one reaction happening in the extrinsic pathway, which is the release of the tissue factor, which combines with factor 7, and that's it. That's all there is to extrinsic pathway. And this gets activated after tissue injury or trauma. Tissue injury or trauma. The intrinsic pathway has more steps because, well, there is a lot of overlap, and this is just for explaining the concepts. But do you remember how in the last lecture I told you the factor 12 gets activated? Does anybody remember? In the shock lecture we discussed it. Something was activating it. Oh, there was a shock lecture? What a shock. The PAMs were activating it. So something coming from there. But this is not what usually happens. Usually the factor 12 will get activated inside by minor exposure to something happening inside the vessels. Okay. Now, once factor 12 gets activated, it will activate factor 11, 9, 8. But what is important is there are more than one factors, more than one steps in the intrinsic pathway. There are like 4 steps here as compared to just one step in the extrinsic pathway. But even more important is this step, the factor 8 that gets activated. Now, why is this important is because this factor 8 requires a carrier. It requires a carrier, like a vehicle, okay? Like you cannot come to the university without your cards, or mostly cars, or no, Uber. So just like that, what is the carrier for factor 8? It's called von Willebrand factor, okay? So von Willebrand factor is active in 2 different places. It is important in platelet adhesion, and it is also important in the intrinsic pathway because it is a carrier for factor 8, okay? So that's why a von Willebrand factor deficiency is a mixed defect. It is a defect in both primary and secondary hemostasis. It is the only disease which can manifest itself as a defect in both primary and secondary hemostasis. Of course, there are many subtypes, but we are not going there. We will discuss that in year 3, inshallah. Now, the concept here is that there are 3 pathways. Extrinsic pathway we have just discussed, intrinsic pathway we have just discussed. They all combine in the common pathway. You don't need to remember all of these steps. They ultimately lead to the formation of the fibrin. And this factor 13 will act on this fibrin to cross-link it and to make it stronger. Okay, this is what is known as secondary hemostasis. Okay, this is what is. So there are 3 things happening in secondary hemostasis: extrinsic pathway, intrinsic pathway, and the common pathway. And they all ultimately lead to the formation of a fibrin plug, and factor 13 acts on it to make it stronger. But there are certain things which are important here clinically that we'll be applying. For the first point I've already explained, that is the role of Warburton factor. The second point is, see this yellow thing? This is all a phospholipid surface being provided by the platelets, and see this calcium, all of these steps, they require calcium. And where is this calcium coming from again? Okay, now ultimately they lead to the formation of fibrin. And now we are going to take these basic physiological concepts that have been covered with you previously in year 1 as well, and we will apply them in the pathological concepts. Okay, now there is a test known as prothrombin time, INR, that is responsible for measuring the extrinsic and the common pathway. So the PT-INR measures this path and this path. It measures the extrinsic pathway and it measures the common pathway. Okay, then there is another test known as APTT, or activated partial thromboplastin time, which measures the intrinsic pathway and the common pathway. The word "and" is really important. Okay, so both PT and APTT are measuring the common pathway. APTT is measuring the intrinsic pathway and PT is measuring the extrinsic pathway. That's another way of putting it. Okay, now why is this important? Because PT, the factor, what was there in the extrinsic pathway? Only one factor. What was that factor? Factor 7. So if only prothrombin time is prolonged and the patient is not on any drug, it is very likely, and if it is a young child and based upon the clinical presentation, it is likely that there is something wrong with factor 7. Okay, if only APTT is prolonged, PT is normal, then it can be a deficiency of factor 8 or 9, which is the main things. One is hemophilia A, the other is hemophilia B, or it can be 11 and 12. Remember, these were the 4 factors in the intrinsic pathway. There was factor 12, there was factor 11, there was factor 8, and there was factor 9. If there is anything wrong with these 4 factors, then the APTT will be prolonged. If there is anything wrong with the Warburton factor, will the APTT be prolonged? The answer is yes, because it is a carrier for factor 8. So again, APTT is going to be prolonged. Okay, and if both of them are increased, if PT is increased and APTT is increased, then that means there is a problem in the common pathway. And what are the factors in the common pathway? 1, 2, 1, which is fibrinogen, 2, 5, and 10. 1, 2, 5, 10. 1, 2 multiplied by 5 is 10. At least you know that much maths. Understood? So this is how we differentiate. So PT, so where do we use PT? We use PT to monitor patients who are on warfarin. I will explain this concept in a few minutes. We use this to evaluate patients when in liver failure or DIC, or if we are suspecting factor 7 deficiency. Now, what will happen in liver failure and DIC? Will only PT be prolonged, or will also APTT be prolonged? Both will be prolonged. Okay, both will be prolonged. So this is something that is common. In APTT, we use it to monitor patients who are on unfractionated heparin, also factor 8, 9, 11, or 12 deficiency, and then see liver failure and DIC is common. So let's put it in another way. Usually we use PT-INR to monitor patients who are on warfarin. Okay, so we will ask the patient and they will tell you that yes, they are on warfarin, and that solves the problem. And we use INR, which is International Normalization Ratio, to monitor them. And International Normalization Ratio, I've explained it in the HLS blog, but it's not part of this blog. But it is an important concept that all physicians should know. Although with the advent of the warfarin analogs, it's becoming outdated now. But it is prothrombin time of the patient divided by the prothrombin time of a normal person, which we call a control. And whatever value comes, we raise it to the value of ISI. If you understand the concept, it's fine. If you don't, I'm just going to skip it. And ISI stands for the International Sensitivity Index. Why do we change a PT value to PT-INR? Is because this INR is a standardized version of the prothrombin time, so that somebody who's taking warfarin, and if they travel anywhere or they get the test done from any lab, they still get a standardized, good qualitative report. Okay, so this is the purpose behind it. We call it international normalized ratio. and it is dependent upon something that we call ISI, which is an index of the reagent that we are using to run the test. Okay, so the companies, they calculate the ISI value and provide it with us, and we just feed it into our instruments and it gives us the value. Why is this important? It is important because this INR, we maintain it within very narrow ratios, usually like 2.5 and 3. We have to maintain the patient between that, depending upon their clinical indication. So we need to have a really good standardized report so that we can apply our therapeutics in the patients. Do you understand it or not? Little bit? Okay. Because that concept is not part of the blog. I have to explain it because the word is mentioned. What is part of the blog and what you should know is that we need PT. Number one, concept number one, PT measures extrinsic pathway. Concept number one. Concept number two, we use PT INR to monitor patients on warfarin. And concept number three, it is used if only PT is prolonged and a patient is a young child who has repeated episodes of bleeding and his APTT is normal, everything else is normal, platelet is normal, then it can be a factor 7 deficiency. Okay, that's the three concepts that you need to remember. APTT we use to monitor patients who are on unfractionated heparin, or we are suspecting hemophilia A, B, C, or factor 12 deficiency. And if both PT and APTT are prolonged, then the patient may be suffering from liver failure. Why? Because all the clotting factors are produced in the liver. Okay, or the patient can be in DIC, but that will be dependent upon the patient's underlying physical and clinical condition. And number three, can you give me a third one? Vitamin K deficiency. Okay, we will come to it later on. Now the thrombin is really important, and the reason thrombin is important is in hemostasis, it generates fibrin by converting fibrinogen to fibrin. It activates factor 12, and if factor 12 gets activated, what will it start? The intrinsic or the extrinsic pathway? Intrinsic pathway, okay? And it also activates platelet aggregation and thromboxane A2. So it is responsible for a number of reactions. Thrombin has a central role in the clotting cascade. You see, it is responsible for platelet aggregation. So it is promoting the primary hemostasis. It is also responsible for neutrophil activation. So it has a role in acute inflammation. Additionally, it is also starting the which pathway? Intrinsic or extrinsic? You just told me it activates factor 12, so that would be intrinsic pathway. Okay. Okay. Now, after this clot is formed, so we have taken those concepts again, the normal physiology of hemostasis, and we have applied it in clinical context. Okay, so if a patient presents with bleeding, post-circumcision bleeding, and we do their test and their APTT is prolonged, what will we suspect? We will suspect factor APTT is prolonged. We will suspect factor 8 or 9 deficiency. What is more common, 8 or 9? 8 is more common. Hemophilia A is more common. So we will suspect hemophilia A. How will we confirm it? We will do a factor assay. We will measure the factor 8 level, and if it is low or absent, that will confirm the diagnosis of hemophilia A. This is how we proceed clinically. Again, these concepts will be applied in year 3 heme blog, inshallah. Now, finally, once the clot is formed, we don't want this clot to remain there, right? So there are two systems in the body that is responsible for anti-clotting. Okay, what are those two systems? Number one, there are certain proteins that inhibits the clotting cascade, and number two, there are certain proteins that digest the clot or lyse the clot. Okay, so there are certain proteins that inhibit the clotting cascade, and there are certain proteins that will digest or lyse the clot. These are the two systems that together we call them the anti-clotting system. Understood? Okay, now we are at the opposite end. After hemostatic plug is formed, fibrin plug is formed, we don't want it to remain. So the fibrin lysis basically consists of the changing of this protein plasminogen to plasmin. And the TPA or tissue plasminogen activator that is coming from the endothelium, for example, will convert plasminogen to plasmin, and this plasmin is going to digest the fibrin. What was the role of the fibrin? It was the final pathway, or was the final product, not the pathway, the final product of secondary hemostasis, right? Fibrin plug was what was responsible for stopping the bleeding. Now it has done its job. It has stopped the bleeding. Now we want this to go away, which is part of the repair and resolution mechanisms. So tissue plasminogen activator will convert plasminogen to plasmin, and this plasmin will lyse or digest the clot. Once it does that, it is going to release certain products that we call FDPs or fibrin degradation products. What do we call them? FDPs, well, degradation products. Fibrin degradation products. One of them is important D-dimer. One of them is known as D-dimer. Okay, you're right. One of them, a small molecule, is known as D-dimer, and it has its value in DIC, because you guys just did DIC as part of the, was D-dimer discussed in the PBR? Mashallah, they know. I don't know why I'm teaching them. Okay. Now the proteins which are responsible for inhibiting the clotting cascade include protein C. Protein S is a cofactor for protein C, antithrombin 3, and tissue factor pathway inhibitor. Tissue factor pathway inhibitor is easy. As the name indicates, it is going to inhibit tissue factor. And if it inhibits tissue factor, what will not happen? Extrinsic pathway will get inhibited. Okay. Antithrombin 3 inactivates a number of proteins. You don't need to remember what they are inhibiting. Protein C inhibits factor 8 and factor 5. Factor 5 is a part of the common pathway. Factor 8 is a part of the intrinsic pathway. So these proteins, they are inhibiting the clotting cascades at different points. Some of them are inhibiting the extrinsic pathway. Some of them is inhibiting the intrinsic pathway. Some of them are inhibiting the common pathway. That is the concept that you need to remember. Don't ratify, don't try to remember which is inhibiting what. It serves no clinical purpose. But the names of the proteins are important. Why? I will give you an example. Protein C, antithrombin 3, they are both clinically important. Okay. Now, before I go on, let me recap what we have discussed in the context of anti-clotting. Okay. What we have discussed is there are two systems that are responsible for anti-clotting. There are certain proteins that are responsible for lysing the clot. We call them the fibrinolytic pathway, and it starts by conversion of the plasminogen to plasmin, the action of an enzyme known as TPA or tissue plasminogen activator. And this is going to lyse or digest the fibrin clot. That is one concept that we have discussed. Second concept is there are certain proteins like protein C, protein S, antithrombin 3, and TFPI, tissue factor pathway inhibitor, that inhibits extrinsic, intrinsic, and the common pathways. Let's put it this way, right? So why is this important? Again, all these concepts, they are happening normally, but they become important both pharmacologically and pathologically. Example is, if protein C is not there or protein S is not there, what will happen? Thrombosis will happen. The clot will keep on forming. There is an increased likelihood that the blood will start clotting inside the body. Why? We will discuss it later on. But if protein C is not there, then the clotting cascade will not get inhibited. It's an example of an inherited thrombophilic disorder. We call them collectively thrombophilias, and this is an example of an inherited thrombophilic disorder, protein C deficiency, and protein S is a cofactor for protein C. So that is another example of a rare thrombophilic disorder. Okay, look at antithrombin 3. What is antithrombin 3 doing? It is inhibiting a number of factors, right? It is inhibiting a number of factors. Now, if there is something that potentiates means increases the action of antithrombin 3. If there is something that increases the action of antithrombin 3, what will happen? It will inhibit the clotting cascade more effectively, and the clot will not form, right? So can you name something that does that? Heparin. This is the mechanism of action of heparin. Heparin has many forms, but one of the things that it does, it inhibits antithrombin 3. And it inhibits it by 1,000, not inhibits, it potentiates, it potentiates the action of antithrombin 3, increases the antithrombin 3 action by 1,000-fold. So that's why heparin is a very effective anti-clotting agent. Okay, so once again, we have discussed the physiology. And we are now applying that physiology in the context of pharmacology and pathology. I've given you some examples, and we will be discussing the examples at 11 a.m. inshallah again of thrombophilic disorders, some of the acquired ones, because that is part of your course and your block. And these are the drugs. These are all, and again, these drugs are not part of your block. The names are not part. The names you don't need to remember, okay? Because they will be taught to you inshallah in the CVP. What I'm trying to convey here, very important, is that these drugs, example is heparin, it increases the action of antithrombin 3, and that's why it's a very potent anti-clotting agent. Now you understand why, okay? Similarly, lepidolin, fondaparinux, low molecular weight heparins, and warfarin, they all act on the cascade that we just saw, and that makes them really strong anti-clotting or anticoagulants. The class of drugs are known as anticoagulants. Understood? So this is why, because you're becoming doctors and physicians, you should know how we apply physiology in pathology and pharmacology. This is how we do that. Understood? Don't ever forget it. Dr. Ram, we will forget it in 10 minutes. Well, at least remember till the end of POD block. Okay, that completes our discussion. 5 or 6 slides more to go of the hemostasis part. Hemostasis part is done. Okay. Now we come to thrombosis. What is the meaning of the word thrombosis? Okay. Now there are some professors here, or at least they used to be, who were very fond of asking this in the PBL, the difference between thrombus and clot. Okay. Now the clot is what happens after. One of the things that differentiate a thrombus from a clot is that the clot happens after death, postpartum. Okay, you have all seen Zabiha, and when we cut them, the blood flows out and it clots. That's a clot. What happens inside a living organism, we call it a thrombus. Okay, okay, blood, mass of coagulated blood form in vitro. Now, what is important as clinicians and physicians, we very, very frequently use the two terminologies interchangeably. We always use them. A clot has formed, a thrombus is formed. For us, as clinicians and physicians, there is more or less no difference. But if you encounter a very purist pathologist, then he may ask you the difference between thrombus and a clot. So please remember that clot is what happens after death, and thrombus is what happens in a living organism. Okay. Now they can form this thrombus. So thrombosis can happen in arteries. We call it arterial thrombosis. It can happen in veins. We call it. And one of the most common examples is deep venous thrombosis, when thrombi, they form in the deep veins. Can you name the deep veins? Popliteal vein. Okay. Now, there are 3 factors which are responsible for clot formation or thrombosis. We are talking pathology now. Okay. We call them together, they are known as Virchow's triad. And they are endothelial injury, abnormal blood flow, and hypercoagulability. Okay. Now, hypercoagulability is easy to understand. It means deficiency of maybe factors protein C or protein S, example. Okay. And there are other examples that will come later on. Abnormal blood flow and endothelial injury we will be discussing now. Now, endothelial injury, remember, there were many, many factors that was there that inhibited thrombosis. Many factors. We didn't mention the names, but we discussed the concept. The concept was there are many proteins that inhibit thrombosis. But if there is endothelial injury, what will happen? 2 things will happen. Yes, tissue factor will get released, and all these factors will go down. All these factors, they will go down. Why? Because now we want the blood to get clot, right? This is what is normally what is happening. So when there is anything that leads to dysfunctional endothelium, it produces more procoagulant effects, for example, tissue factor, and synthesize less anticoagulant things which are described here. Okay. Example, this very frequently happens in atherosclerosis. Now, the normal blood flow is laminar. What is the meaning of the word laminar? Cells are in the middle and the plasma is at the periphery. This is normal blood flow. Okay, this is normal blood flow. Now, what happens is 2 things can happen, turbulence or stasis. Stasis is easy to understand. Stasis means pooling of blood. The meaning of the word stasis is pooling of the blood. So if the blood pools, anywhere in the body, especially in the lower limbs, veins, then the laminar blood flow will no longer be there. That means that this will give chance for the platelets to come into contact with the endothelium. And if that happens, primary hemostasis can start. And if primary hemostasis starts, secondary hemostasis can follow. Okay, what is turbulence? What is turbulence? What is the meaning of the word turbulence? Disturbance. Can you be okay? Have you been in an aeroplane? Have you ever experienced air turbulence? Okay, do you remember the joke that I told you in HLS about the turbulence? Seriously, none of you remembers it. I'm going to tell it to you again. Do you remember it? Okay, no problem. Fresh class, fresh, same joke. Same point. I really don't have time for jokes, but now I've said it, I have to say it. And it is being recorded. Okay, once I was in an airplane, I was flying from here. It was a pretty long flight. And we flew. And when I went in and I was sitting, there was this female sitting adjacent, and she was fully covered before the time of the mass. And she saw me and she turned around and said like that. I said, okay, I wasn't going to, become friendly with you or something like that. And I sat down. But once the plane flew, after a few minutes, we entered an air pocket and we fell like this, okay? And there was severe air turbulence, okay? The whole plane was shaking. And the minute that happened, she turned around, held my hand and started reciting Kalma. And I said, it will be fine, don't worry. 2 or 3 minutes later, the plane stabilized and we came out of the air pocket, the turbulence ended. And the minute that happened, she turned around. And for the rest of the flight, no physical contact or anything. So now you understand what happens in turbulence, right? This is what happens. Now the blood can also be turbulent, and especially if there is aneurysm formation, okay? So this stasis and turbulence can lead to endothelial activation. And if the endothelium gets injured or gets activated, once again, everything that we have discussed so far will happen. That is, the clotting cascade will start. It can disrupt laminar flow and it can bring platelets into contact with the endothelium. Okay, now the examples are immobilization, prolonged immobilization, maybe after fracture or trauma, they have cast over it and they're lying down for a long time. That is going to lead to stasis. Aneurysm, what is an aneurysm? It is an outpouching of an artery in which the blood will be very turbulent. It will be striking the walls when it is flowing through. And there are also pockets of stasis in an aneurysm, and I will show you in a picture how that happens, okay? Now, the hypercoagulable states can be primary or which includes common and rare. All of these will be discussed. All of these will, inshallah, be discussed in year 3 heme block. Over here, we will not be discussing any of these, just the concept that if they are not there, then that can lead to thrombosis. So 3 factors: endothelial activation, factor number 2, disruption in the blood flow, and factor number 3, hypercoagulable states. You need at least 2 or all 3 very high risk of thrombosis. 2 out of 3 is still very high risk of thrombosis. 1 out of 3, not that high risk of thrombosis. If all 3 are present, so every factor that you includes in the Virchow's triad, that is going to raise the, I know the time too, it raised the possibility of thrombosis happening. Okay, so we will stop here on slide number 32, and we still have to do 38 more, inshallah, at 11. Okay, thank you very much. Any questions? Online people, online students, any questions? Thank you so much. Oh, there are 32 things in chat. Oh, thank you, Johanna. You are answering their question. That's why there are no questions, because Johanna is answering. Thank you. Thank you so much. I really want to read this. Yeah. Okay. Okay. Excellent. Excellent. Did you apply? Next year, inshallah. Have you stopped? You can stop the recording.